Well, welcome everybody to this episode of Humanizing Healthcare. And today I am truly honored to have as a guest Chris. And Chris, could you introduce yourself and tell us what you do?
Yeah, you're too kind, Owen, and I appreciate our collaborations over the years. My name's Chris Harrop. I'm a senior editor at Medical Group Management Association (MGMA). I'm celebrating this month my 10-year anniversary there. My past life before that, I was a journalist. The things that I work on a day-to-day basis are publications, data reports. We do polling initiatives. So my job is probably best to listen really well and then to just think, which ultimately I hope is not all that different than what a practice administrator does. Is that you look at a lot of data, you hear from your people, and you analyze and you look for how can we improve. You know, that's really essentially the same thing when we develop education and content, is to listen really well to the member voices and to make sense of it all, and to not always pick the easiest, most top line answer, but dig into it a little bit deeper. Thankfully, we have you know thousands of members who interact with us on a regular basis. Our benchmarking data sets where we have a lot of information that we can dig into there, and events, webinars, and other places where that community actually continues on. And it's a great time to do it because we're celebrating our 100-year anniversary as an
Yeah,
association here
yeah.
in 2026. And uh, you know before I was at MGMA, before I was a journalist, I was a history major, and that I get a kick out of that. So it's never a dull moment in healthcare management. So uh, this is a really great time to be doing all of this work. At least I think so.
Well, that's amazing. So you've been with MGMA 10% of the lifetime of MGMA.
That's right.
10 years, 10 years to 100 years. So that's really pretty awesome, Chris. You mentioned two things that I think are really interesting to kind of kick this off a little bit. You said listen and think. And prior episodes that I've had, guests have always emphasized the idea that their role and their recommended role in management is to listen. And I think that's one of the things that we don't take a lot of time to do. In fact, one of the guests said he made a point of putting on his calendar two 30-minute blocks every week to go do what we call a gemba, which is go to where the work is being performed and listen to what's going on. Think. And think has always been a big thing on of me to not only then listen, but then to regurgitate, to think about, to follow up on, and to act on what you hear. So that's great. Now, so Chris, what are the hot issues that you're seeing today?
I If I were going to phrase it one way, I think the one thing that comes out of thinking about our centennial is that all the issues that were there in 1926 are still with us here in 2026, whether that's managing overhead and supply chains and all of those things. I think as it just as a big concept, a big idea that practice leaders are facing is that the numbers might suggest that the strain maybe has eased a little bit. Maybe turnover is a little bit lower. Maybe operating costs aren't rising as fast as they were, right in the peak of the pandemic. That there's all of these things that they might seem like they've calmed down, but truly, I don't think the strain is actually dissipated at all. You know, I we do polling every single week of medical practice leaders via what's called MGMA stat. We send text messages out to thousands of practice leaders, and we ask them about how's your operating costs year to date versus last year, your revenue year to date versus last year, new patient wait times, and you see a lot of what might be considered stability in those numbers, but I think the reality is that there's a lot of strain underneath all of that. Is that there's a lot of work to you know GPO utilization to help get better rates on your supplies. There's been template optimizations. There's been all sorts of work on the HR front in these practices. And I don't think the burdens are really going down that much. It's people are working much harder to just stay afloat. I don't think that they really tell the whole story. In the same way, it's, if you're looking at, code volumes, for your doctors, and you see, some people are higher, some people are lower. You have to dig a little bit deeper into your pivot tables and really understand what's actually happening underneath the surface. What is actually driving some of that activity? Uh, I think we find that, we're in this era where people expect everything to get easier with artificial intelligence and machine learning and new technologies. And in some respects, it's making real improvements. I think there's a long way to go yet. I think we're still waiting to see a lot of these new tools coming online. Number one, not everyone's implemented them. And two, they're maybe not giving all of the ROI that people expect them to. There's, say, the time burden might go down for certain people on the staff or your clinicians, but how does that actually translate into like a true operational efficiency or an actual bottom line impact? Those are all the things that I think there's a gap in between there right now
Mhm.
from what I've been seeing, and trying to actually get, less pajama time for the docs actually charting in their evenings versus, you know not just another visit that you can add to the schedule with that efficiency gain, but also a visit that you can get paid. In this era of rampant denials and more prior authorizations, I think everyone is still working very hard. I think that's probably a topic that's very close to you, Owen, because it's like the idea of overburden and trying to actually find true efficiency. I think we're still working towards that right now.
And well, again, you make some interesting comments. I like your point about the history of back in 1926, these were issues. Today, they're still the issues. And when I think about that, I think about, well, what can we do to change? Do we want to have the same workflow that we've always had? Are there other things that can happen, such as telemedicine, which may help, which is AI scenario, and agentic AI might be able to help us a little bit. Uh, but I think we're in the infancy stages of those kinds of things. And what I hope happens from this podcast and a lot of other resources that the practice managers have and the leadership have is I like an acronym IKA: information, knowledge, and action. And hopefully, what you do and what we're doing here today is providing information which creates workable knowledge that will lead to the improvements that we have, whether that be seeing one or two additional patients a day, or being able to give a better work-life balance, being able to work better with the team, however it seems to fit. I guess what I'm hearing you say is we have those challenges still ahead of us.
I certainly think so. And it's how you judge the actual return on investment for AI today really depends on how much you want to get out of it. I think a lot of medical groups are going to go out and say, well, you know what? If this makes my docs happy to have an ambient documentation tool at their disposal and it saves them all that charting time, I'm not even going to worry too much about the actual documentation integrity piece. And, we'll work the claims, on the other side of it. That's totally fine. I want to keep my docs happy. The cost of, going out and, recruiting in this market today is worth it enough to me on that alone. But I think it's going to quickly become, in the next year or two, truly trying to make the case that these tools are operationally and financially sound, that you're going to be able to fund the tool based upon what you're actually doing in
Mhm.
savings from operational efficiencies and growing revenue through better productivity. So where any one group falls on that, that's a cultural question. Uh, so
Yeah.
It's hard to say how quickly that will come about, but I think that's the trajectory we're on.
Well, I love the quote that says, "Culture will eat strategy for breakfast," and
Mhm.
we can commiserate and develop the IKA and get the action in place and that sort of thing and move forward with it. But if the culture doesn't support that action, you'll end up wasting a lot of time and resources that could have been utilized other ways. And that's why I like the theme that I have of humanizing, because we have to recognize that the people that do the work are the ones that can really contribute. And
Absolutely.
it's not just the people in the C suite or the manager of that department that has a corner of all the solutions. We really need to get staff involved, but then you have the risk of cybersecurity. You have the risk of them going into Claude or Chat GPT or Gemini or whatever, and doing some research, and all of a sudden there's an interesting profile on your practice out there. There's a lot of things that need to be in balance beyond just saying, I want this application.
It's
Okay.
the tools that are getting used without ever being actually sanctioned by leadership. It's the consumer products that are out there that yeah, people are going to use unless you advise them, here's our tool set, we're going to train you on it, here's what we expect you to do with it, defining what are the actual jobs, or excuse me, the task in your job that
Mm-hmm.
AI should be used for. It's sort
Yeah.
of like when we had the discussion a few years ago about what makes any one role within the medical practice right for remote work, from being able to work from a home office. You have to look at it based upon the work that's being done and does it lend itself to this. So applying a similar litmus test to that makes tons of sense, because otherwise, if you don't dictate the terms and give people the tools and to educate them on how to use those tools and set expectations about what you're going to get out of those tools and to measure and to take corrective action when you need to, having those governance pieces is something that we've spent a lot of time working on. I'd say the last 6 7 months at MGMA is developing more education around what an AI governance framework looks like, not just at the staff level, but also what's the board's role in understanding this. It's like
Right.
you might have a group that's they've got a robust cybersecurity apparatus in their board right now that they everyone kind of understands that now. But I mean, the AI governance and how that needs to actually trickle down through the entire organization, a lot of practices are still working on that. I think we've got, maybe it's about half and half we polled on this. Do you actually have a formal AI policy or governance piece in your organization? About half said no. The other half, it was split between yeah, we do have it, or we're actively working on it. I think we're going to see probably just about everyone working on adding that governance piece and having better formal policies in place, staff education pieces in place, uh, as we get toward the next year or so. Uh, then again, there's also maybe about 10% of practices that we hear from over and over that say, you know what, no, we're not touching AI. So what happens with them, that will be very interesting to see, is to just gauge over time, are they really going to be that obstinate to say, nope, we like it the way it's been? What will actually move the needle for them to actually embrace some of these new tools? I suspect that that may be a little bit inevitable for many of them.
Yeah.
Uh, but again, they are going to want those same rules and governance layers that all these other practices are already working on. Uh, Maybe it benefits them from not being early adopters. That's certainly the case in many things, such as with
Mm-hmm.
telehealth. There were some practices that were slower to get onto telehealth than others. They didn't have to pilot untested solutions back in 2020. They were the benefits of some more better developed platforms that came along afterward. We'll see how that actually works out for them.
The key, one of the key points that what I emphasize though is the 1926 to 2026 we have the same problems. So if we don't take advantage of those tools in that 10% world, that's not doing anything with AI, they're going to be left behind. I don't think there's any question about that. And I think we really need to take a serious look at what we can do with AI. And I like the point of developing the policies and so on that go on with that. But I've seen so many practices where the board will sit there and then develop this policy, and everyone agrees, yes, they raise their hand and say, we want to do that. And then tomorrow morning in the clinic, the doctor says, not no, but hell no, I'm not going to do that. They can do whatever they want. And so you end up with active passive kind of activity, and you end up with a culture that's confusing. And so I think it requires not only creation of the policy and the procedures that go along with it, but the effective implementation of those to optimize or maximize the benefit that you can get from that.
You started us off talking about the Gemba walk. I mean, you have to get closer to where the work is actually being done. We saw this, in the last 15 years with the big expansion of EHRs and actually figuring out what platforms are going to work best. And it's typically the platforms that the doctors and the clinical team are actually going to use, and to be able to not have to find constant workarounds for. Those are the ones that actually get buy-in. uh, Otherwise, you just get left with these tools that nobody wants to use, or they just push it off, and then chart closures get longer. And
Yeah.
you have to get closer to the work, and you have to build some of that buy-in first. And for those that don't necessarily even know whether they would like or not like a particular tool, you have to have the education piece there. We
Yeah.
wouldn't hand a scalpel to someone who's not trained as a surgeon and say, "Here, go at it." It's like, no,
Yeah.
no, we need to set the parameters for how we're going to be successful.
Yes. I agree, and I compliment MGMA in its webinar format and its other communication format, the educational programs, the annual conference, the various other sessions that we have that really do make a difference and give an opportunity for people to be involved. And and that's at the management level more often than not, but that has to translate to the worker level in terms of where we go. But one of the other questions that I have is as you looked at that 50% that have the policy, 10% that don't, and so on, do you have any idea relative to the size of the practices? Because to me, uh, and I'm a proponent of the entrepreneurial spirit of the doctor being able to keep their practice going and that sort of thing. Uh, it seems to me that a solo practice or a 2 or 3 doctor practice that implements AI will have a better chance of surviving in the future than they would have without AI. So, do you have a sense? Excuse me. Do you have a sense about that size issue and how that might kind of fit together?
This is you've touched on to something that maybe I don't think anyone outside of MGMA would really know. We have a white paper that we're developing right now. We did a study on what's we're calling intelligent patient access, and just looking at the number of tools that different practices are using. And we're sort of segmenting and cutting the data, small practices, medium and large, ownership differences, some of the specialty differences. And um, we're seeing like this mid-sized group trough where you have the smaller practices that can just run with something. You've got the large practices that have a good apparatus and infrastructure for setting policies and having rules that cascade down and get well educated across clinicians and staff. That mid-sized group where you used to be able to do everything informally, you start adding more of those tools, but there's not that coordination layer to really help you scale up. That there is a real issue right there. Whether you say that's a 50 provider group between 100, it's somewhere in there, but it's you stop losing that go get them attitude when you're really small and you can just chase things down, versus the ones that are just really big and have the infrastructure that can handle all of that. In between there, it's where it gets really murky.
Hmm. Yeah, interesting. Um, Gosh, I so when you're going through this, and people are querying you and others at the MGMA world, are they asking questions only, or are they offering solutions? Are they sharing their experiences that say we tried this and it worked, or we tried this and it didn't work? How can we find ways to broaden that understanding of this worked, this didn't work, and so on. So, what kind of thoughts do you have regarding related to that?
Yeah, I think that the association space that we're in, that MGMA is in, is a great one because people do frame their questions based upon what they're actually doing. They'll go into our member community online, our member forums,
Right, right.
uh, and they'll say, "Hey, I'm at this type of organization. This is my role. We're dealing with this vendor. Has anyone had the same issues?" Or we're trying to navigate this contract language that we're starting to see pop up. And it's naturally framed in the opportunity, the challenge. They're not just asking for an answer. It's like people are taking all of the context and trying to understand it as best they can because it does matter. The answer on staffing, MA staffing between, say, a physician practice and a hospital is completely. We do learn a lot from the polling, not because, again, we have to get past the top line. We ask a main question in our polling, but we always have open-ended fields for a follow-up. And I think we
Mhm.
learn most of what's actually happening from that. So again, if the numbers say that we're stable, well, the actual context behind that will say, well, we actually added multiple providers, optimized our templates, and added new tools to achieve that stable number. Well, that's a
Mhm.
lot of work to not see much actual movement on the bottom line. So
Yeah. Well, one of the other comments that you made earlier was the idea of tasks. Doing the job. And when we think about AI, we should be able to eliminate some of those routine, redundant tasks that the receptionist or the medical assistant has to do. So there are applications in that arena in addition to the ambient physician component that you mentioned as well. And my sense is that, in fact, one of the themes of this podcast is that efficiency and humanizing, or humanizing and technology, are really not competitive terms, they're collaborative terms, so that the team becomes more cohesive and collaborative to lead to uh, the obvious beneficial outcome of providing that high quality care and successful health outcomes that the practice would have. How do you see that sort of scenario fitting together?
I think because there were so many challenges and AI sprung up so quickly that there's such a focus on, is the new technology, is the new AI tool actually paying off, that we're almost skipping over the rest of the change management that has to happen there, which is, if you can get the task to be done differently, that you can automate them, that you can gain efficiencies, that you then have to redesign the role and to set expectations for what that newly redesigned role actually looks like. Because again, there's a lot of talk in the clinical space and support staff space. Is AI going to replace people? I don't think that that's necessarily been borne out by the reporting and the research that's been done across the industry. Our own polling suggests that only a small fraction of practices have actually redesigned roles after implementing AI. But I think that that's where it's going to head, is that you have to then take a look at the position description. You have to look at the tasks that are done and to revise them, and to then work with your staff that are going to have those new position descriptions revised, and to say, yes, now that we're going to focus on, for those that have top of licensure roles that they need to be focused on, have that conversation and set new expectations. If it's just a matter of getting out from underneath a bunch of paperwork and faxes and actually spending more time with patients, that expectation has to be set. There's the performance management talks, tracking it over time. I think a lot of practices just aren't quite getting there, but they're going to have to. As they start to see things change and realize those efficiency gains, you have to get people thinking that my role has changed here. I still have a role here. It's an important role to play. And ultimately, the new work that they do is oftentimes going to be even more fulfilling. So I think that's a great opportunity that a lot of practices should really think about right now.
I love your term fulfilling, because again, you think about the receptionist who has to do all of this sort of stuff all the time. So what you see is the top of their head. You don't necessarily see them interacting, and setting the tone in that visit with a good personal interaction can be rewarding to the patient, but also rewarding to the staff, so that they feel like they're really doing something that's meaningful. Not to say that getting the right insurance information and the right group number and all that sort of stuff isn't essential. There's more to it, and I think back on my own experiences in the healthcare world as a patient. Too often, I don't get greeted
Right.
uh, by the staff. And uh, so I wonder how comfortable they really feel back there doing all of this, as opposed to interacting and sharing and so on with the customer, if you will, in terms of that relationship. And it's not just the front desk, it's the MA as well, who has to go through, well, I got to get the vital signs and I got to do this and I got to do that. So get the hell in the exam room so I can go see the next patient. Excuse the expression. But, uh,
But
that,
it's true.
that sort of,
We
yeah,
spend a lot of time talking about how we can get physicians to not be staring at the screen in the exam room and actually talking with the patient face to face.
right,
And I think it
right.
holds true, as we mentioned, two very historically high turnover roles there in the group, the front desk and MAs.
Right.
I do think that as you get more of that human element back, and that you, granted, there's always going to be some interactions with patients that are going to be difficult. But frankly, the people that deal with those interactions and get a better understanding of who their patient is as a customer, as a human and an individual, produces better relationships. There's more fulfillment out of that interaction rather than just working the phones,
Yeah.
working the fax, you know, ingesting, entry of everything. I think that does actually have the same effect that it does for physicians who are no longer staring at a screen. It's bringing that human element to all areas of the organization.
Okay. So the thought that crossed my mind as you were sharing that is uh, the uh, the Gen Zs, the millennials, who are constantly on their screen and so on. Uh, there's going to be there's a need to make sure that they humanize as well. And so there's an important part there that the practice can play in terms of developing relationships and helping them understand, how important it is. The 45-year-old mom that comes in and whose son is just graduating from high school and got a scholarship. If the staff knew that and how important that was to the mom, and be able to relate to that kind of thinking at either the receptionist or the medical assistant or both levels, you can really bring compliance to the treatment plan. You can bring a lot of other things that the patient will have as an outcome from that visit, simply by that simple, quick interaction.
And people call that soft skills, but it's truly a very valuable piece of what a practice
Yeah,
manager
yeah,
or administrator has to do. And they
yeah,
do it by modeling behavior.
yep,
When I started working at MGMA, I thought, hey, all of the financial analysis and all the operational stuff. It seemed really interesting. It's really, I love all the details involved in there. But I was kind of learning more about practice management myself when I started here, and I kind of wrote off some of the more interpersonal pieces, uh, and the leadership development pieces and the cultural pieces when I got here. And as I actually spent time talking to practice managers and seeing what they were interested in learning, of course, the operational and financial pieces of practice management are the table stakes, and the personal pieces and being able to have really strong interpersonal relationships to actually be able to grow emotional intelligence and empathy and to model it to staff and to have that drive your culture is as important as any other piece of it. So I think that there's as you kind of spoke to it, there's opportunities to have all the compliance things and all of the actual work come through by having everyone seen a great example and try to match it.
Yeah.
That seems to be the most foolproof plan. That there's no, I don't think there's any one, you can't, there's not just one TikTok that you could produce that gets everyone thinking the same way. It has to be repeated. It has to be observable over time. And I think practice managers are up to the task because nobody wants to be in a culture that feels toxic or just this. There's always going to be strain. There's always going to be uncertainty. Uh, you have to, not to say that resilience is the one thing that's going to get everyone through, because I think we found that there's no amount of resilience alone that does it, but just getting people to see empathy in action, to see really strong personal relationships in action, it it feeds off itself with enough time.
Again, you're great with words because you use the word empathy, and when I think of humanizing, I think of respect, I think of compassion, I think of listening, I think of being able to be transparent, and the empathy piece that goes along with it is just so critical. What I tried to do is to say, think about what you've just heard, and then grade yourself. How well are you doing in any one or all of the aspects of the discussion, and give yourself a medal? So we're in the Olympics. And if you're doing incredibly well, you get a gold medal, silver, bronze, or if you haven't medaled yet, you better listen to this again, because there's so much information that Chris has shared with us that's very valuable. Take this information, convert it to knowledge and action to improve that patient care outcome. So, again, Chris, I want to thank you so much for sharing your knowledge. You're an awesome guy.
Thanks, Ellen.